Hi, I'm Rama Vancheeswaran. I'm a chest consultant and a general physician, but I've been a chest consultant for years, as in 2006, but really worked in respiratory medicine all the way from 2000. Today, my topic is about cough. It's one of the commonest presentations to the respiratory or the chest clinic, and this is mainly because it causes so much distress. So first of all, coughs can be acute, subacute or chronic. The coughs that we normally are concerned about are those that last for more than 3 weeks, because it might be that they need further investigation, but certainly it is recommended that the coughs over 3 weeks are investigated. Now, coughs could be due to so many reasons. They can be due to nasal problems, refluxing, lung problems, medication, other comorbid conditions that irritate the airway. Cough is just a reflex. It is where the lung thinks there's a bit of a problem and it's trying to get rid of whatever there is in the lung. But very often it may not be in the lung, it may be elsewhere. So it's so important to understand the cause of the cough and the treatable traits before managing a person with a cough. Women are much more likely to cough than men, mainly because we've got many more receptors in the brain that are sensitive to coughing and that continue with it. It also tends to occur in as we get older, as women get a bit more into their middle years, because we tend to have children and therefore maybe your sphincters get a little bit looser, specifically your gastric sphincter, from which you get reflux. But very often cough is not straightforward and it's multiple and it's got multiple pathways. So the most important aspect to review a cough is to see when it occurs, whether it is recurrent, how long it's been there for, is it productive, as in is it dry or phlegmy, and what's the timbre of the cough, what does it sound like. So the history, which is the first part of the review of a patient, would be to assess what's going on, how did it start, and what's the story of it. Then the second part would be the examination, because there are many things that could cause coughing. So if it's affecting the lung and it's a purely lung problem, you might get wheezing. But if it's external or in the lower parts of the lung, you might get crepitations or squawks. These are noises in the lung. Also, heart-related problems can irritate the airway, causing cough, and so can some of the medications for blood pressure and heart-related problems. The nose is one of the biggest. Everybody seems to think the nose is independent of the airway, but really your entire windpipe and breathing apparatus starts from the tip of the nose. So if there's a drip from the nose, or inflammation of the nose, or polyps, or sinusitis, or any of that, that can trigger coughing. So there are so many different things that would cause coughing, but the additional bits are sleep and snoring problems, where the cords and the upper airway is so irritated because of noisiness that it can cause coughing. Inhaling of very many things, either triggers such as allergens that cause asthma, or smoking can cause coughing. So coughing is such a multi-mechanistic symptom that is aimed at protecting the lung, but can go a little bit awry, so it can cause more chronic symptoms. This usually then is followed by a full set of investigations. If one thinks it's more asthma and airways disease, then lung function and something called a nitric oxide, a fractional. It's a blow test where you measure the nitric oxide in a person's breath, and that suggests an inflammatory or allergic component to the cough. But then a scan is often done because that rules out some of the common lung problems, such as bronchiectasis, which is where phlegm stays, or chronic bronchitis, or smoking related problems, or bronchial wall thickening, or scarring of the lung, because they all present with coughing. And once one has done those two tests and taken a history, there's a very likely chance of identifying the treatable traits in a patient. So the treatable traits would be your nose or your reflux or the lung problem. And finally, you get a thing called cough hypersensitivity, where the vagus nerve that stimulates your cords and causes coughing just becomes habituated to a trigger, and it just coughs. It becomes something that occurs. And because it does occur so frequently and causes problems, particularly in the pandemic, where some people are so vigilant about people who cough, it might be something that causes anxiety in the patient or yourself, and it does therefore need prompt treatment to stop this habituation and reflex coughing that is occurring because of multiple stimuli. And then once we know what we've got, if it is airways problems or asthma, one can give inhalers. You stop the irritants such as smoking or inhalation of the dust. If there's reflux, there are lots of different things that can be done. Firstly, avoidance of various types of foods such as chili, fizzy drinks, alcohol, caffeinated drinks, all irritate coughing. So once one takes some of these triggers away, and then you can use treatments such as PPIs or Gaviscon to really settle the reflux component. You've got treatments then for the two big areas, so the nasal symptoms and the airways and the refluxing. Nasal symptoms would be either drops or antibiotics that control the inflammation of the nose. And then finally, if it's just habituating coughing because the vagus nerve has been triggered, then one needs to try something to numb the nerve. And again, tablets, and there are multiple medications that work for that. And as we progress into research environments, there are now newer drugs available. But they should be given or considered only when all of the baseline treatable traits are identified, maximally managed, and if still persistent, the symptoms persistent, one can do other things. So cough is common, very common, more common in women than men, treatable, but requires a complex assessment because it's never straightforward. It often includes multiple areas, all contributing to a mechanism that irritates the nerve that causes coughing. So once we've got the understanding of all of the treatable traits, it becomes easier to fix. And then follow-up should ensure that the cough resolves. Cough also takes a bit more time to resolve, dependent on the type of treatment or the correct identification of the issue. I've had a patient whose cough disappeared in one dose of a cough suppressive treatment, and I've had people who've had it much longer and needed many attempts at trialing various different things before it finally went. Some patients have come to me with a 20-year history of cough. Now that is not an easy one to fix, but it is fixable, and it should never be considered just something that one should live with, because it isn't the case. Cough can also, on imaging, be predictive of something more sinister, like a lesion or a tumor. And so it is important to fully assess and investigate longer term coughs.